Our symposia, they always have the same title. It's always called What We Wish You Knew and Why. And for ATTD, the presentations will focus a little more on access and the actual use of diabetes technology. First of all, today, thank you very much for always supporting DDoC and especially the DDoC Voices, and thank you for making sure that we are part of ATTD. Today, Asra will share a little bit about their fabulous project called Decoded, and Tino will talk more about how to bridge the tech gap in underserved regions. We have Noor from the Netherlands who will tell us more about her own experience in accessibility of diabetes technology when you live with another disability. And then Leon will also present the Insulin Consensus Initiative. After, we will have a really open Q&A session, so if you have any questions for our speakers or you would like to make some comments, please feel free to ask them and share it with us. So, for those of you who have had little to no contact with DDoC before, I will try to describe DDoC and what we're doing in a few sentences. So DDoC is not just an online diabetes online community. We are a platform for people living with diabetes to stand on and to use their voice. And we support them by doing so. And I'm really, really proud to tell you that all of our speakers at our symposium today are actual DDoC voices. The DDoC Voice Scholarship allows diabetes advocates from across the world to attend scientific conferences like ATTD and also EASD, ISPAD, and so on, to learn new things, share it with their own community, and bring it back and let everybody be part of this fabulous network. So I would like to ask our DDoC Voices of ATTD and also all of our alumni DDoC Voices who are in this room right now to stand up and show you guys, and we can have a little round of applause for all of you because you're doing such a great job in your advocacy work. And I'm even more proud to tell you that we were able to bring 22 diabetes advocates to ATTD in Florence in person, and another 26 are joining us virtually. They are coming from more than 25 countries, and they live with all kinds of type of diabetes. So we have type 1, 2, LADA, type F, you name it. Since last year, we began to expand our DDoC Voices program and support diabetes advocates in their work beyond conferences. In our DDoC Academy, they can exchange ideas, they can keep in contact online at any time, and they can learn from each other. We have academy sessions where they can organize themselves and share their own skills. So, for example, we had a session on Twitter. We have some DDoC Voices who are really, really good at using Twitter, or now X, and they shared with their fellow diabetes advocates friends how to make use out of it, shared some tips and tricks, and how to use it during conferences. And since August last year, they can also now publish their own articles, videos, other creative work about their impressions, opinions, own projects on our DDoC blog, and it's worth checking it out later. As part of our Doc Days, we bring diabetes advocates again from around the world on a virtual stage where they can also share their own projects with the broader diabetes community. Those live streams, they are recorded and you can watch them all on our YouTube channel if you would like to. And the same applies also to our Doc Talks, where we collaborate with partners from the industry and share experiences and stories about a certain topic. So, before our voices take over the stage, I would like to share a few important dates with you. Please feel free to take a photo of this slide to make sure that you will not miss it. We will be at the Diabetes UK Professional Conference in London in April, also with a symposium. We will be part of the German-speaking DDG in Berlin in May. We have 2 virtual Doc Days this year, one in German in May, end of May, and the other international one in August. We will be, of course, at EASD in Madrid, as well as ISPAD in Lisbon. And of course, we have our virtual World Diabetes Day, which is a special edition of Doc Day on the 14th of November. And now I would like to invite Tadej to the stage. Thank you again for supporting us. And yeah, thank you. Welcome.
Dear friends, thank you very much for coming. It's super important. Every individual that works with people with diabetes and their families hopefully eventually learns that you have to live with it, not us. So this is the reason why it's so important you are here, not just to learn actually, but to advise on how to proceed, because unless you accept something that we believe is super important, it doesn't help you. So that's why I believe it's so important that not only you learn, but also you discuss and give us feedback on whatever we imagine is or perhaps should be important. So this dialogue, this conversation in between all of us is probably crucial. So I'm really pleased. Thank you for doing this. Thank you for supporting all these people, for organizing it. Also thank to Bastian, who is not here, unfortunately, and have fun. Thank you.
Thank you so much today. I like that, have fun. We're certainly here to have fun. Please, everybody, join us. Come down the front if you can. Community-led initiatives are truly changing what diabetes looks like. And the diabetes community has always led the way with that. If you want to think of things in recent times, like the We Are Not Waiting movement, if you want to look at the Language Matters movement, if you want to look at all things like Nothing About Us Without Us, this is all led by community, and it is changing how we think about diabetes. To be on the stage in the program of scientific conferences like ATTD is something that we could have only dreamed about 5 years ago. So how wonderful that we're here kicking off the ATTD conference today. That's probably enough from me. I get to introduce, though, some people who are doing remarkable things, and it is my absolute honour to introduce Leon Tribe, a fellow Aussie, so you're going to get to hear our accent a little bit more, and he's going to talk about something that's new, really new in the diabetes community. It was started by DDoc Voices. It has been launched by people with diabetes to make this happen. It is about the insulin consensus and a petition that's going around right now, and we really hope that you'll be able to support. But Leon, come and tell us all about it and how it happened.
G'day. My name's Leon Tribe. I'm a person with type 1 diabetes, and I'm part of the DDoc contingent here at ATTD 2024. Nothing to declare other than my gratitude for coming. Thank you for taking the time out at the conference to hear our voices. It is genuinely appreciated. A little over 100 years ago, this was the outcome of if you had what we now call type 1 diabetes. Without insulin, life expectancy was in the single digits, and the death was slow and painful as the body used its tissues to create fuels which couldn't be used. To put it simply, with no insulin, the inevitable outcome was death. And of course, Banting and his team changed this, discovering and isolating insulin and then removing the barriers so it was available to all those who needed it. The medical community can be proud of a culture which led to Banting's humanitarian ethos. Literally tens of millions of lives have been saved thanks to discovery and access driven by Banting and his company. The world pivoted from a world where no insulin meant death to where insulin meant a healthy, productive life. And if I took a poll in this room right now and asked, should we withhold insulin from people with type 1 diabetes? There would, of course, be unanimous consensus that this would be a ridiculous proposition. So let's rephrase it to a slightly more difficult question. Should a civilian population be given everything they need to survive in wartime? If we think of the basics, well, there's air, there's food and water, there's shelter. But what about essential medication? A person with type 1 diabetes needs insulin as much as they need those other three things: air to breathe and food to eat. The truth is, I don't need to take a poll. I don't need to ask that question because it's already been answered for us. In 1949, after the horrors of World War II, 196 countries came together in Geneva, Switzerland, to define the limits of war. The world stood together and defined where humanity ends and savagery begins. Along with the Geneva Conventions defining the rules of war, other documents define human rights, whether in war or peace. In general, these are not long documents. They've been translated into multiple languages and they're freely available online. And I encourage you all to read them so you can understand the benchmark humanity set for all of us 75 years ago. So how does modern warfare stack up? It's not well, frankly. This is a subset of the many conventions and articles which are applicable to situations that we see in contemporary wars today. And I'll paraphrase because there's a lot of text on that screen. Humanity has the right to medical services when sick. Hospitals and public health should be maintained. Medical personnel shall be allowed to carry out their duties. Every human being has the right to life. Civilians in war shall be treated humanely and without prejudice. It is clear that participants in many modern wars have no strong regard for the values agreed upon by our predecessors. Many of us in the diabetes community know firsthand the horrors of DKA because we've lived through it. The diabetes advocacy community felt frustrated, angry and impotent when confronted with the images that we're seeing today in contemporary wars. Being a truly international community, many of our fellow people with diabetes, many of the fellow advocates, feared they could be next. And so when it was reported at the start of February that medical supplies, including insulin, were not reaching the civilians in need, it was a spark which ignited us all. Within days, social media channels such as Discord and WhatsApp were employed to coordinate efforts. The idea? To create a declaration which articulates the need for every country, state and group participating in war to remember their humanity, to not sacrifice their values for a Pyrrhic victory. This document could then be used by the international organisations to assert influence on those who degrade us all with their actions. Without reference to any war in particular, this document would be a perpetual reminder of the human values we enshrined after sacrificing so much 75 years ago. A week later, the declaration was finalised and put on change.org as a petition. Within a week, the petition had over 2,000 signatures. The number of signatures grows every day, literally by hundreds, driven by the tireless effort of the diabetes international community. Efforts being coordinated across 6 continents, and the sun is always shining on our global community, and when we put our mind to it, we are unstoppable. To date, this petition has now got close to 20,000 signatures, and as I say, continues to grow. Less than a week after the Change.org petition was launched, multiple translations were made available to local communities, and we created a video reading out the document. It shows how this is truly an international effort without politics, and I'll play it for you now. Many of the faces in this video are here at ATTD. If you have questions about this initiative, I encourage you to talk to them. They'll be happy to talk about it.
As diabetes advocates and members of the diabetes community worldwide, we want to share a shared concern.
In times of conflict, insulin is being restricted in aid, putting lives at risk.
Insulin serves as a vital lifeline for individuals living with type 1 diabetes.
And it's equally essential for many others managing different forms of diabetes that are insulin dependent.
The recent difficulties and restrictions on getting insulin as aid in conflict zones is very alarming. Without insulin, the health of people with diabetes can deteriorate very quickly and the results can be deadly.
Insulin represents survival, and access to it safeguards the human rights to health and life.
Our unified stand. The statement of consensus stands as testament to our collective commitment to safeguarding the right to life.
Ensuring uninterrupted access to care and providing essential protection for individuals living with diabetes, particularly in conflict zones.
We urgently call upon all involved parties to recognise the humanitarian impact of obstructing insulin access.
Prioritizing the health and survival of those reliant on this life-saving medication.
It is imperative to understand that the absence of insulin equates to death for those in need.
Therefore, any barrier hindering insulin access for a region or population must be addressed promptly.
This is a call for collaboration. We extend an invitation for collaborative efforts to enhance and fortify this statement.
Together, our goal is to amplify our unified voice, ensuring that our advocacy for unrestricted access to insulin resonates on a global stage.
Furthermore, this request regarding insulin also needs to be applied to all other life-saving medications for people living with non-communicable diseases.
Please sign and share the Insulin Consensus Petition so you can collaborate with us to help provide equitable access to insulin.
I encourage you all to sign our international consensus and use the hashtag Insulin Consensus when discussing it online. We know many of you are working silently towards similar goals. We need your voice, united with our own, to reach your communities. Help us hold to account those who would diminish us all. Stand behind Europe's legacy in defining what it is to be human, and support those of us who depend on insulin to live, honouring Banting and the values he and the medical community stand for. The link on the screen and the QR code will take you to our declaration. We welcome your support. Thank you.
Thank you. We will be doing questions later, so please, if you do have any questions, note them down and you'll be able to ask our panellists later on. I frequently refer to Tino as the hardest working advocate in diabetes. He really is certainly one of them indeed. If you are anywhere in the online diabetes community, you will have seen Tino. He has a podcast, he interviews people online, he writes blogs, he is very present in the activities of so many people, and also is such an incredible supporter for what other people with diabetes are doing as well. So I'm so excited that I get to introduce him now to talk about access and equitable access now. Come up to the stage, Tino. Thank you.
Okay, greetings. So how is everyone doing this afternoon? Yeah, it's an afternoon, but I know for people that are watching online, we have different time zones and so many things. I think I was a bit nervous, but I just wanted to say hello, and thanks to those people that are already here. Some of the people that I met on the plane while I was flying to this place, they are here. They promised that they'll be here while I speak, so to cheer me, because I need that. Okay, so, I did put that picture? Okay. Okay, so because behind me it was showing sort of like a globe, speaking about the things that we face in our underprivileged or under-resourced communities. So hence, I had to put that picture. All right. First things first, we want to talk about the things that matter most. The demand. Yes, of course, there's a demand, and also there's sort of like, what is it like? Like when we talk about the enablers, we're talking about the enablers and the barriers to diabetes technology in access. Like, firstly, the first things first is that the community needs these things. I myself, I got to learn about the diabetes technology from the conferences that I attended, so which is a good thing. So now people in my region, where I come from, they also need these things because it's critical. Like for people living with diabetes, you always need to see like where you're going, that kind of a thing. So it's always great to have these things. And also due to clinical or clinician interest, when there is a research that is being done, we would always see that like when we are doing a research, the people would be given these diabetes devices or diabetes technology. I think that is where some of the things like the people that are getting to use these resources in our regions, they are part of a research that is being carried out, and thus they will then spread the word to the people that needs to use this kind of a thing, right? And also the international use, as I said the first time I got to use diabetes technology was from a conference that I know, like, okay, I didn't know about this, and now today, proudly, I'm wearing it's not a Dexicom, it's a Symbionic CGM that I'm wearing, thanks to, okay, should I give it a shout out? No, I don't. All right, so now let me focus on the barriers to diabetes technology. So like despite the increasing interest or increasing awareness and interest in the diabetes technology among the low resource populations, there are significant barriers. They are really significant, the barriers that, like for instance, we could talk of costs, as you can see here. Like some families, for example, the middle, or should I say the average monthly salary, it could be 250, and you know that probably a Dexcom could go for 450 a month supply, and then for a pump, you need a pump, it would be costly. So for a family that is earning 250, they cannot afford to buy or maybe just to pay out of pocket to get the CGM that the family could need. So that is just one thing that I wanted to talk about. And also there are other competing priorities in a family. You're not the only one. Probably people from our regions, they could have like 6 children. You also need to be sent to school, so they cannot really focus. Sometimes you'd have to see like some of these people, they could forego, sometimes they are rationing insulin. So mostly they prioritize insulin rather than these other diabetes technologies. They are seen as a luxurious thing, but they are not. They are really a need. We need to have those kind of things. But it's difficult for people from our regions to afford this if we have so many socioeconomic status or economic problems that we could talk about. And also, with the monthly wages that I said, like that are oftenly exceeding, they are really low and the demand is just huge, so they cannot really keep up. So I think these are some of the barriers. I don't want to sort of like talk from the screen and then so you'd know. Right, so next thing, I want to talk about the strategies to increase what we can do. So this is what we wish you knew, or the time is moving, but I'm still here. All right, so the strategies to increase acceptability and uptake of diabetes technology in our under-resourced populations is that implementing the subsidized or donation-based programs is in partnership with manufacturers, governments, NGOs, can make technology more affordable. Like I said, from the clinical, if it's a research that is being carried out, those things will, the people that will be using the technology won't have to pay for anything. It'll be good. Subsidies are always a greater thing, and we could avoid people getting to complications because the government would end up paying more if people are to be taken to the hospital. So I think it just saves us a lot if we do take up this thing. And also comprehensive education and training programs for healthcare professionals and individuals with diabetes care are crucial to ensure effective utilization and understanding of the diabetes technology. So people really, they need the training also, so that it's sort of like upskilling, like I said. It needs to be done. We need to have so many trials. And also please consider the people from the under-resourced populations, like the doctors, for example. You need to get them involved. I know probably so many of you, the healthcare professionals, you're probably doing research, but we've never seen our doctors or our healthcare professionals that take care of us doing this. So one thing that I always say, I say that like the doctors from our regions, usually the knowledge that they're using to treat the people that they see is the knowledge they got when they got trained to become doctors. So it's really bad. We are really behind. So I think we need the upskilling. So please encourage them. If you can collaborate with them, because, I mean, we need also to get to these things, because diabetes is just one thing. We need to improve the quality of life for people living with diabetes, regardless of where we are, right? Next slide. Okay. So, like, these are some of the case studies from the things or the nations that have done so well. So I took the privilege to talk about India, for example. They have these amazing, what do you call it? The Medtronic, the 7.8G, and the Libre Pro and the Libre sensor. They have access to these things, and they're paying it from out of pocket. So these are some of the success stories that I wanted to highlight, and also the Aboriginal communities with that flag. So they've got access to, this is a region that is in Australia. They got access to the Libre 2 sensor. It is because of the research that is being carried out, and I don't know if those people that are doing this research, if they're here. Oh, I don't know if they're here. So in South Africa, they have access to the Libre 1 sensor. They also have access to the Dexcom G7. And lastly, Rwanda. The Diabetes Association, the Rwanda Diabetes Association is carrying out a research that they're doing. It's sort of like a study. So people now have access to the Dexcom G7. So only a few people have access to these things. But our wish and our hope is that maybe everybody else could have access to it. So these are the success stories. And these nations are in the under-resourced under-resourced regions, but they have access to these things. But however, people are still paying from out of their pocket, which is that we could want to change that. So now what are the lessons? What are the lessons to help the future of diabetes technology access in under-resourced regions? For example, I'm not marketing for these things, but it's just something that is probably known by everybody. We know, for example, there's glucomes, digital health solutions that cater to diverse diabetes management needs, and also it's a data-driven, like we need sort of like the data-driven insights and the artificial intelligence. I think people are now taking advantage of it. If you're not, then I think you could be working hard. You need to work smart anyway. So these artificial intelligence, they are there to help us with the things that we need to do. So I'll just have to summarize because the time is not on our side, and I've done a lot of talking, trying to expand my points. So like, what is our request from us as people from the underprivileged or under-resourced communities? So we need simplified regulations, because when these companies want to come to our communities, the regulations should be smooth, should be simple, so that they don't have to fight so many hurdles, because at the end of the day, they want to make money. But we, as people living with a condition, we need access to these technologies so that we can better manage our diabetes that we have, and also improving patient outcomes and reducing healthcare burdens. Partnerships with technology companies, manufacturers, we need those kind of things. And lastly, what is our call to action? Our call to action, I think, as it is written, you need to listen to people living with a condition that you're trying to help to ease the burden. So you need to listen to people living with diabetes. They know what they need, and you know what we need. So we need to come up together. We need to work together. We need collaborative policy and advocacy. So, and lastly, I would just say, let's get involved, let's get engaged, and let's come up together to create the change that this world needs. We need to create it. We can do it together if we are working together, because we are stronger together. And that's the last thing. Thank you for all listening.
Thank you, Tino. One of the things that we haven't actually spoken about before when we've spoken about access is access to technology for people with diabetes with disabilities. And we've got Noah now who's going to come up and speak about that. So I'm really pleased that we're talking about things that perhaps are not topics that get really wide coverage, and this is a really, really important topic. So Noah, thank you so much.
Hi everyone, thank you Renza and thank you Natalie for the kind introduction. It's an honor to be here on this stage talking about a topic that's very close to my heart, which is accessibility in diabetes care. Okay, so hi, like I said, I'm Noor Akça from Rotterdam, the Netherlands, and I've been living with type 1 diabetes for a little bit over 10 years now. I'm a patient advocate and a DDoc voice. And in my free time, you'll usually find me turning my CGM graphs into little pieces like this, which I hope I can call art, but I'll leave the decision up to you. One little moment. Technology problems. Okay, so today I want to focus on accessibility in diabetes technology. And I would like to ask you a question. So, we already talked about access in diabetes. Unfortunately, we can't always get the technology we want or need, and it's usually because there is either access to only a small section of devices or there is no access at all. But what about accessibility? Similar words, different meanings. So my question to you is, are diabetes technologies accessible for everyone? Yes? No? And what about people living with a disability? Are technologies accessible to them? Or maybe I should say us. I'm asking you this question because I was diagnosed with congenital cataract when I was 3 months old. And to keep a very long story short, what that means is I was born with 2 very cloudy eye lenses, which had to be removed immediately after diagnosis, and I started wearing contact lenses long before I could even speak or hold things with my own hands. So thank you, parents, for taking care of that. I just wish that diabetes technology was accessible to us, people living with any form of disability. And although there are lots of options when it comes to accessibility, something as simple as brightness adjustments of the screen would be a huge game changer. But then, what about, look, dark mode? Things like brightness adjustments and contrast can be very important for people living with certain eye conditions. But I also wish more healthcare professionals were aware of the fact that people living with diabetes and another disability exist too. So I wouldn't have to explain why I don't wear glasses every time when I ask for a more accessible pump or glucose meter. And, are you ready? This is the best of all. So I don't get referred to an app when I ask for a new pump, or when I ask to see a new pump in real life so I can make sure I see the screen. And I tried telling them that an app is not the same as a pump screen, but they referred me to the app again. Okay, so I recently realized that I was actually a patient advocate long before I even knew what that was. Because when I was younger, I used to take my old contacts to the playground or the school so I could show to all of my friends and teachers what my world looks like. Of course, growing up with a low vision wasn't easy, but I never really felt different. I just knew that the way I saw the world, that was different, and that was it. But then I was diagnosed with type 1 diabetes when I was 18 years old, and for the first time in my life, I felt different. I'll repeat that. I felt different. Because I found myself in this big world of small needles, no color screens, and nutrition labels. Always fun. But my eye doctor recently said, oh wait, no. I know one thing for sure. The fact that I can stand here today, being able to see the entire audience, all of your beautiful faces, is a miracle. And my eye doctor recently said, miracles exist, and I am the proof of it. So I am, and I will keep on sharing my story, hoping for another miracle in which diabetes technology will be accessible to all. And although I say miracle, it actually shouldn't be. But you know what we say at DDOG, nothing about us without us. Thank you.
Thank you, Noah. What about access to research? That's something that we do talk about a lot in our community. It's participating in research, it's being a part of it, it's being involved in what research is all about. But what about, once there's research out there, understanding what those results are? Because sometimes that can be super confusing. So what if I told you that the diabetes community had come up with a solution for that? Your response should be, well, that doesn't surprise me. Nothing should surprise you when the solution comes from the community. Azra, come and tell us all about Decoded. I hope you all know about this, but if you don't, you're about to have your mind absolutely blown. Remember to keep your questions because we've got a Q&A just after this. Let's hear all about it.
Thank you so much, Renza. It is wonderful to come here, speak to you. It's my first time. So if I make a few blunders, we'll live with them. Diabesties is the mother behind Decoded, and Diabesties' big mama is sitting right there, Jazz, and she came up with this idea, let's simplify research. What is research? When I was diagnosed in 1987, that does age me because I was already 17 plus. So when I was diagnosed, after my first 2 weeks of diagnosis, I went to the doctor with a handful of Jocelyn Diabetic Center paper saying, look what I found out, as if I'm going to go show him something new. So this little seed was in here very long ago. So next one. Where am I? Right. I live with type 1, oh yeah, no, for 37 years, and I'm very interested in diabetes research. I do not have a science background, even though I believe I do with diabetes. I think living with type 1, almost all of us have a science background. This is just a fallacy that we don't. And I said, why should one's limited understanding of medical knowledge and technology, specs and research and methodology, the boring part, come in the way of learning about my condition so I can learn about it and I can talk about it and I can go and talk to you and the doctors who are going to give my prescriptions. Bridging the gap. That's what I became, the tiny 5-foot bridge that's going to go into medical teaching hospitals and say, hey, I just found something new. But of course, it is not me, it is not ever alone. It is always all of us. So at Decoded, we are endeavoring to gather a team that can take complex research with difficult language, with science that is absolutely pure jargon for us, to everyone who's living with the condition, regardless of their country, regardless of where they are based in, their age, or their accessibility. We have been talking about accessibility, but so we thought, let's bring this research, make it accessible to everyone, everywhere, wherever they are able to access the internet. So we went in and we set up a mission. What is Decoded? Let's say we are going to describe the research, we're going to debunk some old theories, and we're going to help you, the type 1, and your doctor make the right decisions for you. That's what a research paper looks like. I don't think that's going to be anybody's casual reading at any point in time. At Decoded, we made it cute. We made it lively. We didn't use words like keyword, we used word wizard. We have vital nuggets. We have summary snapshots and prime insights. Prime insights is the jargon part, which that's the only part. If you can swim through that, the rest of it is no issues whatsoever. Your T1D takeaway is the lively part. That's how the article starts with. And this we learned to change. This was not how we started. T1 takeaway was not what we had at the top of the Decoded website. You, as the voices around the world, we had a little bit of a feedback seminar, and they came back and they said, hey, I want to know how it affects me first before I decide to open that article. So we said, okay, let's move it. We have the liberty to do that. And then we have our summary snapshots, curiosities clarified. Which questions did that article answer for you? But the most important part is the source's voice. Not only is this research from peer-reviewed research papers, it is also being endorsed, approved, and accepted either by the author who originally wrote the research, or by the publishing company and a panel who is part of Decoded on a permanent basis. We have very familiar faces here. Dr. Parthakar is, of course, presenting. We have Helen Murphy. We have a lot of people. If you go onto the website, you will find the familiar names who are part of diabetes research forever. How does a Decoded article get chosen? Now, it's not always Asra saying, hey, we need this done. Let's do it now. Or Jazz, usually with the time difference, me and Jazz do not live in the same country. So we are usually going across a time difference of 5 to 10 hours. And it's neither one of us saying, let's do this. It is people living with diabetes who are our decoders. They are the ones who pick the article that interests them. And they go through it, we go through it, and we decide, right, let's go, let's choose it. And they will use their lived experience, how it impacted them, and how that research could make their lives better. The article is edited, verified by the expert researcher or the panel of academics, and the article is then designed and launched. So it's not a one-person job. Our design team does play a very big role. Decoded is not a summary. It is not the boring abstract. It is not a dumbed-down version. It is a medium for people with diabetes to advocate for their health and using research. A digestible yet accurate representation of that research with visual aids. I love the visual part. I can see some people like Camille there. I see our latest edition sitting right here in the third row. We've got Justin right here. I like to hear the research, or I like to see it. And I know both of these people have made diabetes research very accessible to me when I started going onto YouTube and Instagram and looking for. So this is what Decoded is trying to do. Now, we asked people, what do they think about Decoded? That's when we had that panel. And people came back with very, very direct, clear, very, very clear ideas about what they wanted and how they wanted Decoded to be shaped. They said it empowers us to be bolder with our management, gives us more power, directly as it gives me the language I can use to ask for things that may help me. Why not? I want to go to the doctor and say, I heard about that CGM, or I heard about that finger prick. I would like to use that. Directly, as it helps with explaining the condition in spreading awareness. Isn't that what type 1 is all about? To know exactly what we have and how we have it and how to take care of it. We went in and asked people, what else would you like? And they said, Decoded is obviously, since diabetes is the mothership, is based through India, but I don't live in India. And a lot of our decoders some are in England, some are in different parts of the world, some are in India. And a lot of the research that what Tino talked about and what Noor said is accessibility. Accessibility might not be there in India. It might not be there in Africa. It might not be there in South America. But this is creating awareness of what can be possible and what can be advocated and what can be brought into. I come from Saudi Arabia. That's where I live. We did not have all the pumps 5 years ago. Today, I can proudly say that every pump that's there in that main hall, every single company is present in my country because we asked for it again and again and again. One of the comments in Decoded was, 87.5 are very satisfied with what we were doing. 12.5% said, there is a little bit room for improvement, and there always is. That's why we want to hear your voices. Please log on to the website, write what you would like. The 12.5% said there's not enough articles, and I'm sorry, there's still not enough articles, and we are working on it. And hopefully in the next 2 months, that's going to be a little bit different. So the highlight of the session, though, was that what we asked the people, what would you like and how was the information useful to us? Our patient advocates came back and said, it helped me with the language to explain my condition better, perhaps to their own family and friends. Gives me info on what is out there so that I can advocate for it in my country, even if it's still not available. Helps beat misinformation. Those myths, those wrong information, those things that really could hurt our own management. And living with T1D for 37 years, oh boy, have I seen some myths come my way as well. On our website, that is what Decoded looks like. We have the what Jazz is today, tomorrow, I think, talking about at the concept study. We have demystified a lot of the once-a-week insulins, which is the EDIC insulin. There is different tripilizumab, but I can't pronounce that one. Okay, and I know I'll challenge everybody else, but it's Tzield. Tzield is up there, and we have the Vertex study, and a lot of people told me, why are you putting the Vertex study? For one, it's not over. Two, there's been a difficulty, it's halted. Yes, I'm aware of it, and we have addressed that in the takeaway, T1D takeaway. So, but that is how insulin was not discovered in its purest, best form that we use right now. Human insulin took years to develop, and so will the Vertex study leading up to our cure. And that is what we are looking for, and that is the reason why the Vertex study was included in the Decoded website. And there we go. What's our wish? Researchers, I'm sure there's at least a few doctors here. Please do engage with us when they are publishing new articles so they and we can become partners together to make that research accessible to people with lived experience. Collaboration always wins. Get equipped with language simple enough to have inclusive conversations about your conditions. And that's the website, www.decodeddiabetes.com. We're looking forward to have everybody register and log in your emails, and we will be sending you updates as and when new articles are decoded and published. Thank you so much.
Wow. Isn't it incredible what comes from our community? It really is just truly, truly remarkable. I remember at one of our symposia, I think it was at ISPAD a couple of years ago, one of our speakers, and it was Tom Robinson, he was in at JDRF, and he said, why would you ever bet against the type 1 diabetes community? This is why you never would. These sorts of things, these all came from community. And the thing that I also want you to remember is this is all done in people's own time. This is all volunteer work. And I think that that's something really worth remembering, because this is part of the emotional labour of living with diabetes. We live with a condition that takes so much of our brain power, so much of the time, but we're still trying to do things to make life better with diabetes for ourselves and for our peers. So we do these sorts of things in our own time. It's incredible, it's remarkable, and please, let's give them all another round of applause for their incredible initiatives. Okay, we've just had a couple of little comments come through, but we would love people to ask questions. I don't think there are microphones. We do. We have a microphone up there, so please use the microphone. But just a couple of comments while somebody is running to Emma there. Oh, actually, Emma, go.
Great. You always have to turn it on. That usually helps. I just want to say how wonderful it is to hear from this panel, and especially what stuck with me was Tino and Noor's presentations. They may sound quite different in scope, but I saw a lot of similar themes coming across, and people living with diabetes are best placed to make the interventions that serve them best. And I hope that there are representatives from industry here in this room today. Anyone stand up from industry here?
Yeah.
Good.
Thanks for being here.
Wonderful. So I also just wanted to say that, access to CGM is very important, but it's in other technologies, but it's equally important that we don't get lost in what currently is not being accessed, which are test strips still. So more still needs to be done in the present moment. So just wanted to make that point. Thank you all.
Hold on to that mic for a second, because I'm going to ask you a question there. I totally agree with you. Is part of that because we don't think of test strips as technology? When we think technology, we seem to only think the bright, new, shiny things. But test strips are technology. Is that part of it? Do we need to reframe how we're thinking about things?
I actually would disagree.
Okay.
So maybe I should give a little about me. So my
Yeah.
name is Emma. I work with Life for a Child. I lead our global policy and advocacy programs. And the reason I would disagree with you, Renza, respectfully,
That's right.
is that I think that test strips should be viewed as a medicine.
Okay.
Test
Yeah.
strips for people living with diabetes who are on insulin or, require monitoring for clinical purposes, they need test strips. It's a non-negotiable. It's not a sprinkling on top. But I think that there's still so much work that needs to be done on this topic, and it was only in October 2023 that the WHO Essential Diagnostics List recognized the importance of SMBG, self-monitoring of blood glucose, for people living with insulin-treated diabetes.
Yeah.
And in previous lists, that just wasn't on there. So while access to CGM and really working towards that is something we should not veer away from, companies need to do more. They need to work on registration processes in countries. That is so, so important. While that is central, we can't keep our eyes off the prize when it comes to test strips, because what is happening in the interim, while we are, searching for a brighter future for CGM access in low resource settings, we still need to focus on what's not being accessed today.
Absolutely. Thank you so much. Okay, some comments here. We have somebody who said, thank you for your experiences, for sharing your experiences in such a didactic and motivating way. And Leon, this is after your talk, so the statement would be impactful in the future, considering there will be more natural disasters owing to global warming. So that's really relevant there as well. Okay, yes, we've got a question. We've got a microphone coming. Thanks.
More a comment and thank you. My name's Alicia Jenkins. I'm an endocrinologist from Australia, but I'm also the president of Insulin for Life Global, and also I work with the IDF Western Pacific region as the chair-elect. Particularly as Leon was pointing out, there is a relatively recent but absolutely devastating situation arising in the global response to getting insulin and other essential medicines into people, particularly in man-made conflicts. I've been working with Insulin for Life for 24 years, and normally we could get supplies in within 3 days to a week. And we did that with massive support from the DDoC community, and are still sending in supplies usually every week into the Ukraine. But there are recently several other countries where the supplies are there. They're ready to go. We can get them there within 2 or 3 days, but there are blockades by recipient countries and those around them. I think we need both a top-down and a bottom-up approach, and the IDF and the UN and other organisations and parliamentarians for diabetes are working with that. But I actually have more confidence that the DDoC and the lived experience community will help do this. You helped break the blockade into Ethiopia when the governments were saying no. Dr. Talang Mofokeng, the UN Special Rapporteur for the right to health, made a very powerful statement in November that got very little airplay about how people are weaponising access to medical aid. Now, I think the use of the media, including the social media, which many of you here can do so well, I think will be absolutely key. And I'd like you to all sign, as I have done, the petition, and also help in any way you can, so that we can help resolve this life and death situation that's happening for many other people around the world. So thank you for what you have done, but also for what you will do.
Thanks, Alicia. Thank you. All right, we have some, yes. Okay, we've got some questions that have come in on the GDoc Facebook channels for people who are watching the live stream. Hello to all of you. Okay, Noah, this one's for you. How did you pick your current pump? And is it accessible enough for you? You might need to speak right into the microphone so we can...
Could you help me understand the question?
Yes, sure. So, well, let's start with the first part. How did you choose your current pump? What was it that made you go, that's the one for me?
Okay, so do I just speak or do I have to just test? Yeah. It was mainly because of the color screen. That was, I think, the only reason why I chose it.
Yeah, okay. And so the next part of that was, is that accessible enough, or is there still more that could be helpful for you?
I think it was one of the most accessible ones, but of course there's always room for more improvement.
Yep, absolutely. All right, Tino, I've got a question for you. This has come from Anita, who is joining us all the way from Indonesia. What approach needs to be taken for diabetes tech access in low to middle income countries? Is it government? Is it community? How does it work? Who needs to be sort of driving it?
Like I said, in closing, let's come up together. Let's get engaged. We need to do this together. No man is an island. We need our support. We need to get the hands on the table together so that no one has to blame anyone. We need to do this together. No one can do it alone. Yeah. So I think that's my short answer.
Okay, fantastic. Are there any more questions in the room? Otherwise, yes, we've got a question over here.
So, hi, so I'm from the industry, and massive thank you to the patient advocates who are here. I've worked very closely with Sana and Anita both, as well as with Huban, and as far as Decoded is concerned, it's generalized comments, that's it, and it's not exactly a question. So, for the first time, we did a study with them, with the Meethi Zindagi group that Sana runs in Pakistan, and actually, it opened up a lot of the blind spots that we had from the industry side. So, massive respect again to Sana that she took up the endeavor, and they were actually the ones who were driving the whole thing. Sana and Anam, they were taking care of the questions and other things. So definitely we need to take into consideration what the patients want, and I guess the industry is opening up to that. But there is another thing that we've noticed. When we were trying to find a lot of patient advocates in the underserved countries or the LMIC countries, we didn't exactly see a lot many people, one or two people. Like for Pakistan, I could only see, Sana. For Indonesia, there was only Anita. So we need more Sanas, Anitas, Renzas, out there who could come to the industry also. As far as LFAC concerned, we work with LFAC. We have CDIC also that is, I'm from Roche actually. So, it's running there. But one thing again that comes to notice is, you can provide patients strips, insulin, maybe medication, maybe visits. Most of these projects are usually, they have a repository of their own. In a few countries, these repositories are going back to the government. In a few countries, nothing is being done. They only register it locally. But the question is that oftentimes we don't see patients returning back to the doctors who are working. They are, rationing insulin, although there is a required set amount of insulin that can be shared with them every month or whatever the visit is planned. So why not use your voices to let patients understand that insulin rationing or strip rationing per se will never help them, no matter how many access projects are out there. So perhaps, we could do something on that. We could align with you, we could align with someone else. You want to reach out to us, there are lots of us here. Not only myself, there's other companies there too who work or take part in different access projects driven by them. We need patients to understand why this is important and why this is being provided to them from the industry end, from the government end, or via partnerships. Because unless and until they use those insulins or they use those strips, no benefit can come out of any access project. So they need to start using it properly. So this was something that I saw. I thought maybe I could share it here. Maybe something would be done about that.
So my question back to you, so hold on to that mic. Have you asked people why they're not coming back?
Yes.
And what do they say?
2 reasons. 1, they don't want to prick, right? 2, insulin is still considered the last end of any medication. For type 1, it is essential. Yet they don't use that because in a lot many Southeast Asian countries, it's a myth that this is the last part, and if you don't even respond to insulin, you're dead for good. Although for type 1s, it's essential. Same goes for type 2s, even if there are access projects for them or for GDM, it's the same thing. Oh, it's the last part. Now we're going to die. So this is the thought process. So again, the voices from, from the own community, those are the most powerful ones that you can get back. So maybe, this could be something, at least, not all the countries, but the LMIC countries, the low middle income countries. Perhaps the patient advocates could do something for that.
So I think that I'm going to sort of paraphrase that and talk a little question about that, and Azra, I'll get you to answer it. But I guess what we're wanting to think about here is people who are perhaps not returning for more insulin or for more strips.
I think one of the projects that we do with Diabesties is a project called Back to Basics. And people can log in and ask for a session, not in a doctor's setting, but on a very personal level. And where we try and make our workshops, we do at least 4 a month. We make our one-on-one sessions fun. We are not talking about the horrible things that are going to happen, and we don't talk about pricking your finger, because that's the last thing anybody really wants to do, and I was one of them. What you said is true. There were years that I would avoid pricking my finger simply because I don't like it. So yes, as voices, as NGOs, there are many that are working towards that. And if you access Diabesties website, you will see huge resources. And Jazz Seti makes these gorgeous videos, which is how I found out about Diabesties myself. Brushing my teeth early in the morning, I was looking on YouTube and I see this girl talking about what is reality and what is the doctor's version of our diabetes. And that lived experience is what makes patients come back and makes things. We have conducted 80,000 back to basic sessions per month. That is since January 80,000, February was another 80,000, and somebody told me, oh, by the way, for March it's 83,000. So we are talking to patients in order to open up from lived experiences. We are not doctors. I'm not a doctor, but I am somebody who's lived with it. So if somebody says, I don't want to prick my finger, I have to make it, that job has to become accessible then. Why would you rather do it even though you hate it? Not an easy task, but we are trying our best.
But I think what you said there, there's so much in there, but the relevant thing is that it's that community-led education, because it's done differently. It really is done differently. The stigma, the shame, the judgment, but being able to have somebody who says, yeah, I know, pricking your fingers, it's not great, rather than you've just got to do it. Because nobody wants to do it. I am yet to meet, so I've had diabetes for 26 years nearly, and I've been working in diabetes organisations for 23 of them or something. I am yet to meet a single person who has said, I really love doing diabetes stuff. Gosh, today I really want to do diabetes. No one says that. We would rather be doing anything other than that. So when we have these sorts of solutions that are founded in community, and that we know work because it's something that would work with us, and then that they're rolled out to reach numbers like the Diabesties group is, like Metis Indigi is, and other groups as well, like DDoC is. These are the sorts of things that have people coming back for more and returning. Jazz, why don't you add to that? Have we got a microphone? Oh, and then Bridget.
Can I add something 1 second, Jazz?
Yes.
Sorry. Because you mentioned we need more Sanas from Pakistan, Renzas from Australia. I don't want to brag, but we have 300 alumni DDoC voices from over 60 countries, and they have, I don't know how many, almost a million years of lived experience with diabetes, and they want to share their experience with you, with the industry, with HCPs, people interested. So please get in touch with us and we can connect you. I mean, that's why we are all here, because we want to work together and change things, make a change. So let's start talking and, yeah, make something great happen. Sorry, Jess,
No,
I
of
had
course,
to add it.
absolutely. I just had a comment on the question, and I think what the panel said is absolutely right. So I'm from India as well, and we run a lot of these access projects ourselves. The question about why people are not coming back is not a straightforward answer. It depends on so much of where they're coming from. So maybe somebody's not coming because they can't afford that day's trip. Maybe somebody's not coming because they don't get food on the way. Maybe somebody's not coming because they don't have a fridge at home. Maybe they're not coming because they feel stigmatized where they go, right? So I think to say that it is your fault that you're not coming back because insulin is the last option, no, I think that's a very dated myth. And I come from India. I deal with these kids every single day, right? Looking at it way more holistically, having peer support, it is the key. It is always the key to make access projects sustainable. You can give the insulin, but teaching them how to use it, having that community element in, not making them feel stigmatized, taking care of all the other things that they depend on to come to you. You might have a center, but if they can't reach that center, it's not going to happen, right? So I think that's what we need to do better. We need to understand where they are coming from to understand why they're not coming back.
Yeah, that's absolutely true. Thank you. And now, Bridget, where did you go? Oh, behind you. Yeah.
Hi there, my name is Bridget McNulty. I'm the co-founder of Sweet Life Diabetes Community, which is South Africa's largest online diabetes community. And I'm the current chairperson of SA Diabetes Advocacy, which is our umbrella non-profit covering all the organizations of people with diabetes in South Africa. I want to kind of pick up this trend and then ask the next question. So I'm hearing what Renza says about doing advocacy is just another thing that we have to do when we're living with diabetes. I've been living with diabetes for the last 17 years. And I'm hearing people say we need more of these individuals around the world, and I agree with both. But I'm curious how we get to do it in a way that we don't have to be doing it in our own time, and that it doesn't only have to be volunteer-led. Because I don't think advocacy should only be volunteer-led. I think the work that we're doing is so valuable and so important that we should be able to be paid for our time. And I don't know how yet. In South Africa, we haven't figured it out yet. But it's getting to a point now where it becomes unsustainable, and it also becomes exhausting because advocacy fatigue happens a lot of the time when you're just doing it in your spare time all the time. So any insights from the panel, any insights from anyone in the room, I would really love to hear. Thank you.
I'm going to throw that to the panel because you're right. How often, and I'll ask this of the advocates in the room, how often have you been asked to do something and you've been told that the gift would be exposure? We'll share your blog post. We'll share your Insta exposure. My husband's a musician. He gets asked to do things for exposure as well. And the response is, we die from exposure. Exposure doesn't pay for our insulin. It doesn't put food on the table. It doesn't pay the rent. It doesn't pay the mortgage. So I'm wondering if our advocates here have got any gems that they can contribute about, what do you say when you're asked to do things and asked to do it for love or goodwill or to better the community, but not actual reimbursement for your time and expertise, because no one else can do what you're doing. No one else can do the lived experience bit. Azra, you look like you want to say something.
I'm kind of watching Jazz as well, because she's basically dedicated her life to do that. I'm coming in at a different place in my life where at this point I've worked for 30 years and I could get out of work when the coronavirus epidemic hit. And when I was deciding to go back, diabetes came my way and I just found my place. The pleasure I get, it is more me that I'm getting out of the work I'm doing rather than what diabetes is getting out of me. Yes, the time difference and everything does make sometimes a little bit challenging, but if you find people with lived experiences who are at that point in their life, appreciate them, take them on, and let them grow with you. That is the way, because everybody needs to pay their bills. So if you are not able to provide the finances that somebody can take it up as a career, then look for people who are at that stage. Just because somebody is on the other side of, I'll put the number 50. So if somebody's on the other side of that age group, don't just assume that, oh, she'll be too old to understand what's going on, or he won't know what to do.
That's so true, as somebody on the other side of 50. Can I also just point out, just wearing my DDoC hat for a moment, that part of DDoC is Doc Labs, which is a consulting arm of what we do, and we absolutely pay our advocates from there because, of course we do. Of course we do. Because that expertise cannot be found elsewhere. And in most instances, I can't tell you early in my career how many times I was sitting on panels and I knew I was the only person who wasn't being paid. Got exposure, apparently. Hi.
Hi, Renza.
Hello, Jim.
I think the other thing to add is that you can always say no. And if you aren't willing to say no, always ask for reimbursement, for payment for what you're being asked to do. It's fair to do that, and there should be an expectation amongst anybody organising anything that you will be paid and that you are going to ask if they don't offer it. So I think part of the problem is actually within our own community, we don't level set very well. And we do offer up a lot of our time and effort. We need to be cognizant of that and act accordingly and make sure that we are asking and we're making a very big point of it.
Yeah, good comment. And Emma, Emma, I'm going to come to you, so hold on to it. But I'm wondering, has anybody else in the group got anything they'd like to contribute to this? Because I am guessing, I mean, Leon, how does something work, for example, like with the insulin consensus? That was just something that nobody asked you to do that. That was just the community doing it. So, but I know how much time, I saw how much time was being spent on that. I didn't spend any time on it, but I saw what the community was doing. How do you balance that, though, with something that you feel compelled to do? But I know that you also sit on advisory boards and things, and there's no payment. So how do you deal with that? Have you had those conversations with people?
I wish I could say that I did, because I'm listening to this conversation and I've been asked to speak at a conference in a few months' time, and I never raised the issue of money, and I probably should have done. But I was happy to speak because I knew I was educating them on something which was going to help the community, was going to help other people with diabetes. So I'm speaking about technology with diabetes. In the case of the consensus, and I'm not the primary driver of that document. There's other people which have driven that. I'm merely the guy up here speaking about it. To me, that was done because I'm a human being. There's no money there. You do that because it's the right thing to do. But yeah, we should. In the case of advisory councils, where there's a clear ask of you to be involved in something because you are bringing expertise to the table, there should be money involved. Now, it's fair to say that I'm guilty as charged as others as well, that I don't have that wherewithal or that confidence, I guess, to say, sure, and here's my hourly rate. But we damn well should.
Yeah. It's a hard conversation to have. It's not an easy conversation to have. There is still a power imbalance, whatever way we look at it, there is still a power imbalance in healthcare. And we're mere patients, apparently. And yet our expertise and what we provide can't be done by anybody else. We're experts. Emma, what did you want to say?
Many hot topics going on right now.
Yeah.
But one of the hotter topics I would say that's really gaining a lot of traction is, anyone heard of meaningful engagement of people living with diabetes? And I think any organization who says that they value meaningful engagement needs to be thinking about remuneration for advocacy efforts. Don't talk about it, be about it. That would be my advice. And I think, it might be nice to hear from Tino, I guess, because Life for a Child has recently, we're actioning this, and we're actioning it through a project, the Changemaker projects. Yeah. We're paying the 8 changemakers who are implementing community advocacy initiatives for the projects themselves. But when we made the call for applications, we said, your budgets can include paying yourself for your time. And we're also paying our mentors as well. So I'm happy to be very transparent about that, because to us, that is what meaningful engagement encompasses.
Well, thank you so much for that, Emma. So the thing is, I think advocacy on its own, it's a lot of work. I think you cannot just do it if you don't have the passion to do so. It's something that you feel you need to do because it's right. And now, for example, let me just say this. In Zimbabwe, there's no project or any workshop about diabetes that can happen without my knowledge, without my presence. Sometimes they might have to postpone if I'm not there. like because of the things that I know, the things that I do, the organizations I work with. So it's a good thing, and also for what Life for Child is doing, like for example, giving like people honoraria to say, hey, we might not be able to pay you, but just recognizing or just offering like an honorarium, that could be good, because there's a lot of work that is happening. I have to be thinking about this. Okay, fine, what is the best idea? Then how can I help somebody who wants to do, who has gotten a project that he has? Then, so I think it's just, then we have to work together, and valuing such things could be good. Not to say, hey, it's for exposure. I mean, I don't need exposure from anybody. If somebody says that, then it's done for me. I don't, because I could be, somebody is getting paid for the things that I'm doing for free, but then we need to just liaise and then see how best we can work together so that it will be smooth. So yeah, I guess that's what I'll say. Thank you.
I really hope that this has given everyone in the room a lot to think about. I always say that if you're in this room and you're a health professional or you're a researcher, thank you, you are an ally. I also say that if you are fortunate enough to be at a diabetes conference and there are people with diabetes, if the DDoc voices are there, go and find them, search them out on the program and sit in those sessions, go and find them and talk to them about the work they're doing and how we can support you with your work. Because we speak a different language. We speak the language of community, we speak the language of people with diabetes, and it's a language that the wider community out there understands and responds to. So please come and talk to us about what we can do. We've got 2 minutes left, so I don't think we've actually got time for, how quick can your question be? We've got one, okay, Rob, go. We're going to run a minute over. Go.
I know we've talked a lot about this, but I think it really reinforces why the insights from diabetes patients are so important, because there really is no benefit coming back to them. They're doing it to give back and build the community. Insulin Consensus is a great example. No one went into that project thinking, how many hours can I bill for this, but what impact can I have? And we've all talked about, and we know as diabetes advocates and creators, that there is a tremendous amount of burnout because there often are not financial incentives for sharing your voice or getting involved in the community. And when people get asked to do many projects, it adds to the diabetes burnout, because no matter what your A1C is, at the end of the day, you still have rent and mortgage and basic bills and things due, no matter where you're from. And so I think that really does reinforce why patient voices are so important. And in this room, it's important to realize that many of these people are giving of themselves with nothing coming in return meaningful from a financial perspective, but community and collaboration are what allow us to have these conversations publicly to help people understand what other burdens are coming for patients with diabetes outside of day-to-day diabetes management.
Yeah, absolutely. That's Rob from Diabetics Doing Things. You should look that up. Thank you very much. And you've got the last word. You've got 43 seconds and counting.
Thank you. My question is for Asra. I understand that the project Decoded is aimed mainly for people with diabetes, right? What about the doctors? Because I have the feeling that nowadays doctors, with all this amazing revolution that's going on with technology related to diabetes, they are kind of being left behind. They don't know as much as we do. It has happened to me recently. I went to see a doctor and I talked to her about Night Scout and so on, and she wasn't, she didn't have an idea what I was talking about. So how do we keep our doctors informed about our technology?
When we were introducing Decoded throughout India as well, and in Saudi, I go and talk about it, we try and tell the doctors and ask them to take it to their patients. So let's do it the other way around. Why can't people living with type 1 take it to their doctors and say, hey, can you have a look at this, register there, and you will find, it won't take up a lot of your time. Most of those articles have a reading time of 5 minutes by the time we're done with it. And that will make it definitely something they can have a look at, and maybe it'll spark an interest where they will actually go and read the original research paper and see if it can help in their clinic. I come from a medical background family, and my own mom, when I tell her about certain, she's like, really? I had no idea. And that's exactly what I see in my own household. My mom is retired, my brother is still working as a cardiologist, and there are certain things he didn't know. And when I wanted to go on a pump, he discouraged me. He said, don't. There's far too many decays happening with people who are using pumps. That was such a general statement to just throw away. And now I give him the research. So I think type 1s and type 2s, and we as the people who are living with diabetes and need that, because we still do need their signature on those prescriptions. So we need to teach them as well.
Thank you so much, everyone. We have run over time. Please thank Natalie, Azra, Noor, Tino, and Leon. Thank you for being here. Gosh, what an honour to kick off ATTD with this talk. Thank you so, so much. As I said, come and find us. We are changing what diabetes looks like. Come and hear how we're doing that. Thanks a lot. Bye-bye.